The People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia now comes in an even more concentrated formula, with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels, and the product undergoes rigorous testing at every stage, which allows them to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
People's Pharmacy listeners can now try CocoVia for 25% off by using the code Peoples25 at cocavia.com. That's COCOAVIA.com. For decades, we've been told to avoid red meat. Then some studies said the risk was minimal. What should we believe? This is the People's Pharmacy with Terry and Joe Graydon.
If experts can't agree about how to interpret nutritional studies, how's the public supposed to keep up with changing nutritional guidelines? It's not just red meat or processed meat like bacon or pastrami. Some new research suggests that even poultry might pose a problem.
Dr. Aaron Carroll helps us interpret risk. What should we worry about, and when should we relax?
Dr. Joanne Manson led the VITAL study, which looked at the possible benefits from fish oil and vitamin D. What did the data reveal?
Coming up on the People's Pharmacy, making sense of confusing statistics.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
Everyone knows that eating red meat is bad for you, right? Except the data are surprisingly slippery. A few months ago, several articles suggested that meat might not be so bad after all. Recently, another analysis showed a link between meat and cardiovascular disease.
For clarification, we turn now to Dr. Aaron Carroll, Professor of Pediatrics and Associate Dean for Research Mentoring at Indiana University School of Medicine. He's also Director of the Center for Pediatric and Adolescent Comparative Effectiveness Research. Dr. Carroll's most recent book is The Bad Food Bible: How and Why to Eat Sinfully.
Welcome back to the People's Pharmacy, Dr. Aaron Carroll.
Thank you very much for having me.
Dr. Carroll, it seems as if food fights are the biggest controversy in medicine today. And you've written a really fascinating article in the New York Times, as usual. The title, Meat's Bad for You, exclamation mark. No, it's not, exclamation mark. How experts see different things in the data. Well, tell us about this latest study about meat. It's got a lot of folks up in arms.
Well, there were a bunch of studies, actually. They were published, it's got to be like a couple months now ago in Annals of Internal Medicine. A group of researchers got together and tried to look at all of the evidence as to how meat affects health. And they conducted a bunch of systematic reviews and meta-analyses. They looked at how diets with meat affect health. They looked at how meat consumption and amounts affect health. They looked at relationships to death, to cardiovascular outcomes, to death from those outcomes. They analyzed it in a bunch of different ways, and the gist of what they found was that the actual evidence for a big link between meat and health is small in absolute value and not of great quality with respect to the evidence. And so based upon all of those studies, I think there were 4 of them, they wrote a set of recommendations. And the recommendations basically came down to, given that we know with not great certainty about this link, and the link appears to be very, very small for most people can probably keep eating the same amount of meat that they have been eating for some time. And as you can imagine, that is quite controversial, as it flies in the face of nearly every other recommendation from every other group, which would argue that we need to eat much less meat, that meat is associated with terrible outcomes, including cancer, including death, including heart disease, and that everybody needs to eat less meat.
And in most of those other sets of recommendations or guidelines from other groups, red meat in particular and processed meat in double particular are seen as particularly negative for health.
So eating, for example, a hot dog or bacon, oh my goodness, what a sin.
Yes.
It just drives a lot of nutrition experts crazy.
Yes, they're quite sure that the links are real, that the links are large, and that if we could convince everyone to eat less bacon, for example, or eat less steak or eat less hamburger, that we would see massive changes in the health of the population. And so lots of groups were very angry at this new set of research and studies and took exception with it. Other groups supported it and thought it made quite good sense to look at the literature and the research this way.
So, Dr. Carroll, how can intelligent, well-educated people come to such different conclusions based on essentially the same bunch of data?
Well, we should first say that, even intelligent, well-intentioned people can get quite passionate and tribal about arguments about these, and that even when their intentions are good and they believe that they're in the service of science and truth, that they can become wedded to one side or the other in ways that probably aren't productive. But even with the best of intentions, people are going to disagree on stuff like this for a variety of reasons. One is that we just only have a certain kind of evidence. The vast majority of research with respect to how do nutrients affect health is what we call observational research. We get a bunch of people together, we ask them what they've been eating for the last 10 years, we look at how healthy they are, and then we try to correlate what they've been eating with health. The problem with that is numerous. One is that it's incredibly hard to look at high-risk outcomes because still in the scheme of things like heart attacks and death and cancer are pretty rare. And so unless you're focusing on a very, very high-risk population, the numbers of these bad outcomes that occur in studies are pretty small. And of course, if you look at high-risk populations, that doesn't translate well into what happens to not high-risk populations, which is what recommendations are supposed to be written for. Secondly, because we have observational research, it's never going to be causal. It's always going to be confounded. And that means that, people that eat a lot of, let's say, bacon might also tend to smoke, might also tend to drink too much alcohol, might tend to be poor, might tend not to exercise. All of those things are certainly associated with bad outcomes, and those might be the cause. It's very hard to tease out what happens with one nutrient. Another problem is that while the relative risks can be high, in fact, the one that's often most cited is the processed meat. Serving a processed meat a day will increase your risk of cancer by 18% over the course of a lifetime. That's a relative risk. That means that, compared to your old risk, it went up by 18%. But if your starting risk was only 2.5%, then that 18% increase means you go from 2.5% to 3.2%. That's not as big a deal as 18%. For most of these studies, the absolute potential risk increases are much smaller than that. And so for an individual, if the risk goes only up by 0.5%, then that means that if 200 people make the change, 199 will be unaffected. One will. On the other hand, some people argue we should be looking at things at the population level, that if we have 1 million people or 2 million people, then that same risk increase might save 10,000 people. Of course, 1,990,000 are unaffected. But, when we talk to individuals about what they should or should not eat, they care about their individual risk. A lot of people who are pushing some of these recommendations are much more focused on the population risk and the population level. That's not how individuals think. That's not how people think. And a final reason I think that people will often, with good intention, really disagree about this has to do with, should we take preferences into account? Some people really, really like meat. And it may be that they're willing to take that tiny absolute risk in exchange for getting to eat lots of meat. Now, the counter to that is people will say, well, we don't ask people if they like smoking. We unequivocally tell them smoking is terrible for you and you should never, never, never do it. But those things are not comparable. The risk increase for smoking is on the order of like 10,000% or 20,000%, not 18%. And that's, of course, the relative risk. People who smoke quite a bit will increase the risk of certain cancers by literally that amount, 10,000 to 20,000%. When the risks are that high and that clear, preferences shouldn't come into account. But when they're small, 5, 10, 15% in a relative risk, then it might, in fact, it probably arguably is reasonable to say that people should get to choose. We take on risk every day. We drive, we ski, we scuba dive. All of those things are risky, and yet we say it's okay because people, adults, can make decisions to take on risk if it's for things that they enjoy. And for a lot of these things, the absolute risks are very small.
Dr. Carroll, one of the challenges, of course, is that august organizations, the Food and Drug Administration, the Centers for Disease Control and Prevention, the American College of Cardiology, the American Heart Association, various organizations, especially in the health field, put out guidelines. And once something is in a guideline, it's like if you're a doctor and you don't tell your patients not to eat meat, you will be spanked. You're not living up to the best practice of medicine. Tell us a little bit about, moving from beliefs, which is often where we start, to guidelines, even when the data changes.
Well, here's part of the problem is that there is no one accepted methodology for producing a guideline. In fact, different organizations will often submit or produce, I should say, guidelines on the same topic that come to different conclusions for that reason. Some organizations, like the United States Preventive Services Task Force, do have a much more rigorous methodology, which is why a lot of the guidelines they put out come out with what is known as an I rating. Like an A rating is like big effect, we're pretty certain, listen to what we're saying. Then a B rating might be a smaller effect with certainty, or perhaps a big effect with less certainty, but we're still pretty sure. And then, of course, like a D rating might be don't do this. There's just evidence not to do this. But a lot of recommendations get an I rating, meaning we just don't know. Like we don't have adequate evidence to determine what to do. And for instance, whether or not we should universally screen kids for autism, which seems like just a no-brainer, gets an I rating from the USPSTF because they say we just don't have enough evidence to know what universal screening would do. So when it comes to something like, should we eat a lot of meat or not, they'd probably say I. We don't really know. The effect is small. It's not certain. Benefits and risks are even. We just don't know. But most organizations don't do that. They want to tell you to do or not to do something. And so they wind up coming out with instructions even when we're not terribly sure. And unfortunately, this leads to reversals. For instance, for decades, well, certainly for years at least, if not decades, the USDA was telling people to limit how much cholesterol they eat in a day. And it's only in the most recent set of guidelines that the evidence finally caught up to them, and they're like, yeah, cholesterol is really not a nutrient of concern. It turns out that what you eat in cholesterol is not the driver of cholesterol. So avoiding all those eggs probably didn't make much of a difference. Well, but that's not what they said for decades. For decades, they said, oh my gosh, you got to limit your cholesterol. We got to be eating egg whites. You have to limit your shrimp. You got to be really on the ball for this. There was never a hedge. There was never a, well, we're just not sure of the evidence. It's always with certainty. And unfortunately, because I think organizations speak with such certainty, even when the evidence is only observational, even when it's potentially confounded, even when the absolute risks are very small, that we get stuck in places where it's very difficult to reverse themselves. And I think that's where a lot of organizations are finding themselves right now. After a long time of arguing that we are certain you must do this, it's very hard to turn around and say we were wrong.
You're listening to Dr. Aaron Carroll, Professor of Pediatrics and Associate Dean for Research Mentoring at Indiana University School of Medicine. He directs the Center for Pediatric and Adolescent Comparative Effectiveness Research. His latest book is The Bad Food Bible, How and Why to Eat Sinfully.
After the break, Dr. Carroll will explain the difference between relative and absolute risk.
What's the NNT and why does it matter?
We'll touch briefly on statins, cholesterol, and diet. What actually makes a difference?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. Kaya Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's Kaya Biotics.com. Use the discount code PEOPLE for $10 off your first purchase.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by CocoVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today, we're trying to make sense of changing nutritional guidelines.
Our guest is Dr. Aaron Carroll, Professor of Pediatrics and Associate Dean for Research Mentoring at Indiana University School of Medicine. He directs the Center for Pediatric and Adolescent Comparative Effectiveness Research. He's a regular contributor to the New York Times Upshot column and has written 3 books debunking medical myths. His latest is The Bad Food Bible: How and Why to Eat Sinfully.
Dr. Carroll, you have mentioned the difference between relative risk and absolute risk, and a lot of our other guests have also discussed this. But, I would have to say journalists are in part to blame. And in a sense, you're a journalist. I mean, you do write for the New York Times after all. But, if you're a journalist and say the relative risk is maybe a 15% reduction or a 15% increase, that sounds kind of sexy. That almost sounds like it means something. Whereas if you say the absolute risk was 0.7%, who cares? I mean, that's like,
7 people in 1,000.
Yeah, it didn't do much. Why should I pay attention to this article? The headline's going to be boring. So how do we basically change not just the health professionals' approach, because they do the same thing when it comes to medications, but also the writers, the journalists, and then hopefully the readers who really will begin to understand, oh, yeah, that relative risk of 17%, that doesn't tell me anything.
Yeah, I wish I could give you a good answer about when this is going to happen, because the cynical part of me says it'll never happen. I mean, there's a reason that every advertisement that you see, that every doctor trying to get you to do something, and that every news story you see is always going to cite the relative risk, because it's always going to be bigger. And journalists and media people want clicks, they want views, they want people to read, and telling you that something is going to raise or lower by a large amount is always going to get more attention than, yeah, it's really, really, really small. And so almost every single story you will ever read that seems to you to be frightening is going to be a relative risk. Now, of course, if you read the articles that I write, I'm laser focused on the absolute risk, and I make this point over and over and over again because this is almost my biggest pet peeve. But, if there's a disease out there and it has a 50% chance of killing you, and I reduce it to a 25% chance of killing you with a pill, that's a 50% reduction in risk, but that's massive. I mean, I dropped you from a 2 in 4 to a 1 in 4 chance of dying. That's huge. But if the risk of something killing you was 0.0005% and I reduced it to 0.00025%, that is also a 50% reduction, but it affects almost nobody. Tens, if not hundreds of thousands of people would have to take the pill before they would see a benefit.
And of course,
that's what we call the... Yeah, go ahead.
Oh, well, I was going to say the latter scenario is a lot more common.
Oh, yes. I was going to say almost every drug you've ever taken is much more like the latter one. There's a statistic we could call the number needed to treat. Basically, you figure that out by taking 100 and dividing it by the absolute risk reduction. Like how much did your absolute risk go down? So in the first scenario, if we went from 50 to 25%, that's a 25 risk reduction. 100 divided by 25 is 4. That means for every 4 people that take the pill, one's going to get a benefit. That's amazing. Almost nothing in medicine works that way. On the other hand, if the absolute risk reduction is, let's say, 0.1%, then the number needed to treat's 1,000, meaning 1,000 people have to take the pill for one person to see a benefit, and 999 will not. That's almost everything we do in medicine. It's certainly almost everything we do with respect to food. And so we're asking thousands of people to change their diets forever, knowing that maybe one may see a benefit and that all the others will not. It's perfectly rational and reasonable for lots of people to say, I don't want to do it. It's just not worth it. I'd rather live, the way that I want to live, unless the risk is really high. Now, of course, if the risk is really high, if they're in a high-risk group, if it's going to make a huge difference, then of course it makes sense. People with celiac disease should not eat gluten. We're not talking about a tiny absolute risk reduction there. We're talking about a massive risk reduction there. And that's real. But for most healthy people, reducing gluten is going to make almost no difference whatsoever. And so therefore, there's really not much reason to do it.
Now, Dr. Carroll, one of our favorite examples of absolute versus relative risk reduction comes out of an advertisement for, I think it was for Zocor.
No, Lipitor.
For Lipitor, okay. And so this advertisement, which I'm sure you have seen, said, 30% risk reduction,
36% risk reduction.
Sounded like a lot. And what it came down to is over the course of 5 years, in the placebo group, 3 people had a heart attack. And in the Lipitor group, 2 people had a heart attack over the course of 5 years. And that was your 30%, 33% risk reduction. It doesn't make a lot of sense, does it?
Well, it would if there were 10 people in the study, but it's very likely there were thousands of people in the study. And that's the point. It's really the absolute risk that matters. Did it go from 30% to 20%? Or did it go from, 0.003% to 0.002%? Those are really, really, really different things. But of course, the news and the drug company, everyone else is going to call it, relative risk reduction of about a third. And that's... It can scare people,
right.
It can drive people to behavior change, but it's not an accurate representation of your individual benefit.
Now, while we're on the topic of cholesterol, a lot of people have been told and understand that it's a bad thing to eat foods that are high in cholesterol. So
it's important. Yeah, it's important to understand that, the vast majority of the cholesterol in your body is actually made by your liver. Because, of course, cholesterol has a function. It helps in moving things around in your body. And so still, people thought, people that eat a lot of cholesterol are going to have high cholesterol. And they did some studies, they were observational in nature, that showed that perhaps people that ate a lot of cholesterol had more associated or slightly higher levels on the whole of cholesterol. But then finally they got around to some randomized controlled trials. And they actually also got around to doing some better research even with the observational data. And they took people, even high-risk people, say with diabetes, and they randomized them to, hey, you eat a couple eggs every day for a month, and you eat no eggs for a month. And then we'll check your cholesterol. And then we'll have you change your diet, and we'll wait another month, and we'll check it again. And they found that for the vast, vast, vast majority of people, it didn't matter. That the cholesterol level was being produced by the body. It had nothing to do with how much cholesterol they were actually consuming. And these studies are not new. A lot of them have been, decades old, and still it took until, I think it was the 2015 guidelines, for the USDA to finally change their tune and, catch up with the science and say, you know what, eating cholesterol is not that big a deal. There are lots of other things that are related to it. Some people think saturated fat might be related to it, but actual cholesterol, the idea of eating eggs, is not what drives you to have high cholesterol. But it's amazing that this still hasn't permeated people's consciousness. I can't tell you how many people are still looking, trying to go to egg beaters or to other egg substitutes or, eating egg white omelets, which are a crime against nature, and in order to try to reduce their cholesterol. It just doesn't work. Ironically enough, I wrote about this a couple years. I think it was one of my first articles in the New York Times, and it arose because my daughter loved eggs and really wanted to have eggs for breakfast every day. And my wife, who's a nurse practitioner, was really against it. And we were sort of like not arguing about it, but debating, because I was like, the evidence does not show this is a problem. And that was really when I started digging into the literature on that. It was in our first book that I wrote. I've certainly written a bunch of papers on it, and everyone is finally caught up. And now, my daughter and my wife have, eggs for breakfast most weekdays, which also makes the dog very happy because he loves the scrambled eggs. But, it took this kind of like change, even in my own household, to get even my own family members to understand that there's just no evidence for this. There just isn't. And in fact, there's evidence against it, that consuming cholesterol for most people doesn't make a big difference. And even for the people it does, it's an incredibly tiny absolute difference.
Well, Dr. Carroll, even when a massive study comes out, like the one in the Annals of Internal Medicine about meat, or even when studies come out and they go, that saturated fat problem that everybody's been worried about for decades, it may not be as bad as we all think. Even when there's data, people's behavior doesn't change much. And so once the study has disappeared without a trace, once it's out of the headlines, once your article has sort of disappeared into the great internet, people are still told no more meat, avoid saturated fat, watch out for cholesterol. It's going to give you a heart attack.
And for sure, don't eat any salt.
Yeah, that too. Yeah, and well, here's the thing. I would say there's both pessimism and optimism here. I think, the pessimism comes from the fact that, like, we have not stopped having these arguments, and we will continue to have these arguments. The optimism is, I don't think most people are listening. You'd have to live under a rock to not know that lots of people think that eating meat is bad for you. And most Americans, I think, have just stopped listening. And the same thing I think is going to happen with salt. The same thing is going to happen with a variety of things, because we continue in the sort of academic world to continue to argue about these things and then get upset when people refuse to listen. I'd argue that people are sort of acting rationally. They're hearing that there's not certainty. They're hearing that, even if there's some relative risk reduction at a population level, that for an individual, it doesn't matter too much. They're hearing that, everybody should change their behavior, but we're not necessarily sure if there's confounding factors. So I don't know. They might be acting rationally. Now, people who think this stuff is terrible for you will tell you I'm doing everyone a disservice and that, the fact that people aren't listening is a bad thing. I'm going to come down on I think in this case, there's not nearly the certainty or the absolute risk that so many believe, and therefore it's quite rational that people aren't listening.
There's another area where people are really at the mercy of their health professionals, in particular, their cardiologist, and in extra particular, their interventional cardiologist. So changing gears here for just a sec, there has been an ongoing controversy for decades about the value of angioplasty and a stent in patients that have something called stable angina, and I'll let you tell our listeners what that means. Because for years, an interventional cardiologist would squirt some dye into a catheter that would go into the heart, and there'd be some blockage in a coronary artery, and the person had no symptoms.
And so the person is told, you're a heart attack waiting to happen.
You need a stent, and you need it like yesterday. And so a lot of stents, a lot of angioplasties have been done, and a lot of bypass surgeries have been done over the last 2 or 3 decades to, quote unquote, prevent a heart attack. Well, there was a study that kind of undermined that thinking, and it was, a lot of controversy. A lot of cardiologists pushed back. But then not long ago came another study, the big kahuna of studies, and once again it said, medications and lifestyle changes are just as effective at preventing a heart attack or prolonging your life as having a stent placed. So can you put this all into perspective and how a patient who is told you're a heart attack waiting to happen is supposed to react?
Well, part of the problem is that we recognize when it comes to medications and to even food and a lot of interventions that the placebo effect is a big deal, that if people believe they're being treated, that can have a massive effect on their outcomes. With respect to procedures, we rarely care or do that because we just assume procedures work. If we see a benefit, how could it be placebo effect? Nobody could will away a heart attack. Or will away heart pain. That can't happen. And so stenting must work. So the big study that happened a couple of years ago was an actual randomized controlled trial where they had strict criteria for who met stable angina, and then they randomized them. And so half of them, they basically threaded the catheter all the way up there and then put in a stent. And for half of them, they threaded the catheter all the way up there and then did nothing. And they didn't tell the cardiologist and they didn't tell the patient whether or not they got stents. And then they checked them out weeks later and they couldn't tell which ones had the stents or not because they had the exact same outcomes. That's horrifying because it means that the placebo effect is real. Even with respect to this, that the benefits people were seeing were not related to the stent. They were just chance or placebo effect, and it's real. Now, of course, cardiologists were very angry about this because we put in a lot of stents, and they argued against the study about, the stents that I use are only for sick patients or this or that. But we know that lots of people are getting stents who meet criteria for not doing them. And then the more recent study confirmed it. I mean, again, we've seen that for some of these, that when we actually do placebo-controlled, randomized controlled trials, that the benefits are not nearly as drastic as people think. And I don't want to just pick on cardiologists. This happens for lots of procedures. My favorite one was in the early 2000s, arthroscopic surgery for osteoarthritis of the knee was like the most common procedure done in the United States. And then they finally did a randomized controlled trial where they gave 1/3 of the people arthroscopic surgery, 1/3 of the people got lavage, which is basically they just wash out your knee with saline, and 1/3 of the people, they made an incision, twiddled their thumbs for 20 minutes, sewed it up, and told them they had arthroscopic surgery, and they all had the same outcomes. And today, arthroscopic surgery is much less common. Gluing for debroplasty, for certain fractures of the vertebra. A lot of these, when they finally put them down to randomized controlled trials, it turns out the procedures perform no better than a sham procedure or just placebo effect. And again, horrifying, but we don't do really, unfortunately, well-designed clinical trials for too many things, and we just assume this stuff works, and we assume it makes a big difference, and then years later we find out we were wrong.
Dr. Carroll, we are almost out of time. What message should our listeners take home today?
I think that the best one is that it's totally reasonable to, first of all, ask your physician when they're prescribing or recommending something to you about what's the real absolute effect I can, that I should expect to see from this. And the second, I think that too often we only look at one side. We look at the benefits or we look at the harms and not both sides of the story. And with all of these, there are potential harms, there are potential downsides of making these changes, even if those are joy. And those should be measured against the absolute benefit you might see or the absolute harm reduction you might see from making a change or undergoing a procedure. And you got to think about both sides.
Dr. Aaron Carroll, thank you so much for talking with us on the People's Pharmacy today.
Anytime.
You've been listening to Dr. Aaron Carroll, Professor of Pediatrics and Associate Dean for Research Mentoring at Indiana University School of Medicine. He's also Director of the Center for Pediatric and Adolescent Comparative Effectiveness Research. He has co-authored 3 popular books debunking medical myths, has a popular YouTube show called Healthcare Triage, and is a regular contributor to the New York Times' The Upshot. Dr. Carroll's most recent book is The Bad Food Bible, How and Why to Eat Sinfully.
After the break, we'll talk with Dr. Joanne Manson about the clinical trial she led called VITAL.
What questions were the scientists trying to answer?
A randomized controlled trial like VITAL is considered a scientific gold standard.
They examined both vitamin D and fish oil.
What helped and how much? What didn't help at all?
You're listening to the People's Pharmacy with Joe and Terry Graydon. This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verisana.com. That's VERISANA.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by CocoVia, offering plant-based nutrients in the form of cocoflavanols for brain and heart health. Online at cocovia.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Many people think there's no science to support the use of supplements. Our next guest has been conducting well-controlled, large studies to examine that precise question.
Dr. Joanne Manson is chief of the Division of Preventive Medicine at Brigham and Women's Hospital. She's also professor of medicine and the Michael and Lee Bell Professor of Women's Health at Harvard Medical School. Dr. Manson is the principal investigator of the VITAL trial.
Welcome back to the People's Pharmacy, Dr. Joanne Manson.
Great to be here.
Thank you.
Dr. Manson, you are the principal investigator for the VITAL trial. Would you tell us briefly what you and your colleagues were hoping to discover in this trial and how you went about it?
So the vitamin D and omega-3 trial, VITAL, is now a completed randomized clinical trial in more than 25,000 men and women nationwide in the United States, looking at the effects of vitamin D supplements at a dose of 2,000 IUs a day, and also omega-3 fatty acids, EPA, DHA, fish oil, at a dose of 1 gram a day in the prevention of cancer and cardiovascular disease, where we were able to look at the independent effect of each of these supplements. And we could look separately at vitamin D, separately at omega-3s, as well as their effects in combination. And we treated the participants. It was a double-blinded trial. They were taking study pills from a blister pack, a calendar pack, and the intervention went on for a little over 5 years. And we recently published the findings, and what we saw were some promising signals, but overall no really clear-cut benefits of the vitamin D or the omega-3 fatty acids in preventing cancer or cardiovascular disease. But what where we did see the promising signals were for the omega-3s. There was a suggestion that those who had low fish consumption at baseline, those who came in eating less than the average amount of fish, which was 1.5 servings per week, they did have a significant reduction in the primary endpoint of major cardiovascular events, heart attacks, strokes, CVD deaths. And in the overall trial, we did see a significant reduction in heart attack with the omega-3s, about 28% reduction. For vitamin D, we saw a promising signal for reduction in cancer death, that once we accounted for cancer latency, that we looked at those who had been in the trial for, let's say, 2 years, there was a statistically significant reduction in cancer death. But we did not see a significant reduction in the primary cancer endpoint of total invasive cancer. So the results are complex, but I would say both of the interventions, both of the supplements, had promising signals that we want to follow longer. We want to see if over time the benefits become more clear-cut, or whether over time these benefits just appear to go away. So longer-term follow-up is needed. And at this point, we're certainly not recommending that everyone in the world begin taking vitamin D or omega-3s, but actually there are some subgroups who may benefit. Those who have low fish intake may want to talk with their healthcare provider about taking an omega-3 supplement. If they're vegetarian, there are algae-based forms of the omega-3s, of the fish oil or EPA, DHA. And for vitamin D, the signals were promising. There were no adverse effects. And so we're saying if you're already taking 2,000 IUs a day, there's no urgent need to stop based on the results of this trial.
Dr. Manson, please explain why this kind of research is so crucial to making determinations about what people should do. We call RCTs, randomized controlled trials, the gold standard, and this is kind of the platinum standard because it went so long and it was so well controlled. That compared to what we would perhaps refer to as epidemiological studies, where we look at populations and they tell us what they're eating or what they're not eating. So tell us the significance of this research, please.
Well, it is very important to have randomization. The process of randomization, which is like flipping a coin, everyone who enrolls in the trial is randomized to either the active or the placebo group by the computer. It's a totally random, flip of a coin process. This ends up balancing out all the other risk factors for the endpoint of interest, especially in a trial this large, 25,000 plus. We were able to have very similar distributions of cigarette smoking, physical activity, dietary factors, a history of high blood pressure, diabetes, high cholesterol. All of these variables balanced out between the active treatment group and the placebo group. Therefore, any result that we saw, we can feel reasonably confident, especially for the primary and pre-specified secondary endpoints, was due to the treatment itself and not to other factors. When you're looking at people who choose to take supplements, who take, for example, a vitamin D supplement or a fish oil supplement, sometimes there are other factors that can, what we call, confound the associations. So people who take supplements may be more health conscious. They may be more likely to exercise or to follow a healthy diet or to be more compliant with medications that have been prescribed for them, such as high blood pressure treatments or statins for high cholesterol, other medications for high cholesterol. So sometimes you see a lower risk in those who are taking these supplements, but it's not a cause and effect relationship. We often say in epidemiology that correlation does not prove causation. There could be a lower risk correlated with taking these supplements, but the lower risk may be due to other factors, such as people who take these supplements are more physically active.
But doing a randomized controlled trial takes care of that.
It takes care of virtually all of those factors. If the trial is large enough, everything looks very similar in terms of other factors, risk factors, lifestyle behaviors. They get balanced out by the randomization process.
Dr. Manson, I think a lot of people are confused about supplements because there have been a number of articles written in the last several years by health professionals who say, oh, don't waste your money. It's just going to be expensive urine. These dietary supplements, these vitamins, these minerals, they don't do anything.
Or even fish oil.
Or even fish oil, for that matter. There have been studies that say, it's pretty much worthless. And now we have this study which suggests that, it actually might in higher risk patients or people who aren't eating fish, that they might see a reduction in heart attacks. For example, if we look back at one of those early statin studies involving Lipitor, it used to be advertised that it lowered the risk of a heart attack by around 33%. So relative risk reduction, not that different from what you found.
Yes, for heart attack itself, the results were quite similar to what's seen with the statin, though overall for total cardiovascular events, heart disease, stroke, CVD, death, the results have been more impressive for statins. However, there's also some evidence from what we call a meta-analysis. We just published a combination, combining all of the different randomized trials that have been done of the omega-3s and looked at whether there's a dose-response relationship, that there's a greater benefit in those who take the higher doses. And there does appear to be a dose response. So we're now interested in testing higher doses of the omega-3s, which may confer greater risk reduction for both heart disease and stroke. The dose that we tested did not have benefits for stroke, but did show a reduction in the coronary heart disease outcomes.
Now, Dr. Manson, we're looking today at also the question of guidelines and how guidelines may be guided, in fact, by research. And I'm wondering if you have any thoughts about how the VITAL trial might contribute to guidelines about what we all should be doing.
Well, I think that guidelines really need to start to take into account subgroups of the population who may benefit more than others. Very often, especially in primary prevention, the guidelines have been much broader, in general for the total population, don't take this or do take that. And very, very few treatments or preventive modalities will ever pass that test, that they will be of benefit to everyone in the population very, very broadly. But I think that the various experts and clinicians, researchers looking closely at the VITAL findings will see that there is a clear signal that those who have low fish consumption had a reduction in their cardiovascular events, in their heart disease events looked at separately, and those who started out with higher intake did not, and that guidelines could include recommendations specifically for people who have higher or lower intake of these nutrients from the diet. I think that would be an important step forward. We'll have to see if the guidelines will be modified, but I think that there may also be an interest in seeing other trials of, for example, the omega-3s for CVD reduction, because most of the earlier trials were in populations that already had heart disease, already had a history of cardiovascular disease. VITAL was one of the very first trials to look at primary prevention, people who did not already have a clinical cardiovascular event, to see if omega-3 supplements could prevent a first heart attack or a first cardiovascular event. So perhaps with an additional trial showing benefits of omega-3s, maybe even greater benefits with higher doses, and also this dose response in terms of if you start out with low intake of fish, low intake of omega-3s, you may be more likely to benefit. That could be enough to really influence the guidelines for omega-3 supplementation. And for vitamin D, it's unlikely that there will be a major change in the guidelines at this point, because overall, the results of the vitamin D supplementation trials suggest that what has already been recommended by the Institute of Medicine, now known as the National Academy of Medicine, of 600 to 800 IUs a day of vitamin D, that does seem to be enough for bone health. Higher doses have not clearly shown greater benefits, and so far there isn't compelling evidence that higher doses will reduce cardiovascular disease or total cancer. There is a promising signal there for cancer death that needs to be explored further. I think there are a number of studies that can be done to delve more deeply into those findings, but I don't think it will, at this point, lead to a change in the amount of vitamin D recommended. Well, that said, we did see safety of 2,000 IUs a day.
Yeah, I'd like to pursue very briefly, because we only have a minute or two left, Dr. Manson, and that is the vitamin D, what I call it the anomaly. There's a lot of data to suggest that people who are low in vitamin D, perhaps because of where they live, because perhaps they also use sunscreen religiously. And so if they're naturally low in vitamin D, there are a lot of consequences. We've seen epidemiological studies suggesting high blood pressure and arthritis and cancer. We could get down a long list of things that have been attributed to low vitamin D. But unfortunately, a lot of the clinical trials, the randomized control trials, have not shown dramatic benefits from supplementation. Why do you think that is?
Well, first, when the low vitamin D, these associations are found, it's usually based on a blood marker for low vitamin D. And so it's you can't be sure it's a cause and effect relationship. So people who have a low blood level of vitamin D do tend to have less time outdoors. They may be less physically active. They may have a less healthy diet. They may have underlying disease that interferes with vitamin D synthesis. It could be a marker for poor health. It's not necessarily cause and effect relationship. That said, we do know that it's tremendously important to avoid vitamin D deficiency, and that's why for everyone it's recommended to get at least 600 to 800 IUs a day. And if it can't be achieved from diet, if people are not having, for example, fortified dairy products, or they're not having fish, which can be high in vitamin D, or mushrooms or foods that are sources of vitamin D, then they should take a supplement. And I generally think that 1,000 to 2,000 IUs a day is very reasonable. We documented safety over 5 years with 2,000 IUs a day. So if anyone has any concerns about whether they're getting enough from diet or having the foods that contain vitamin D, it's very reasonable to take a low to moderate dose supplement. But avoid mega dosing, because mega dosing, getting above 5,000, 10,000 IUs a day, unless your clinician is recommending that specifically, can be harmful.
Dr. Joanne Manson, thank you so much for talking with us on the People's Pharmacy today.
Thank you. It's great being here.
You've been listening to Dr. Joanne Manson. She's chief of the Division of Preventive Medicine at Brigham and Women's Hospital. She's also professor of medicine and the Michael and Lee Bell Professor of Women's Health at Harvard Medical School. Dr. Manson is the principal investigator of the VITAL trial.
We spoke earlier with Dr. Aaron Carroll. He's professor of pediatrics and associate dean for research mentoring at Indiana University School of Medicine. He's also director of their Center for Pediatric and Adolescent Comparative Effectiveness Research. Dr. Carroll has co-authored 3 popular books debunking medical myths. He has a popular YouTube show called Healthcare Triage, and he's a regular contributor to the New York Times, The Upshot. His most recent book is The Bad Food Bible, How and Why to Eat Sinfully.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia, maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
If you would like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1200. You can also find it online, peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Have you found changes in nutritional guidelines confusing? Tell us about it.
At peoplespharmacy.com, you can also sign up for our free online newsletter or subscribe to the free podcast of the show. Never miss another episode.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money. If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in. Even a small donation can make a big difference. All you have to do is go to peoplespharmacy.com/donate. Whether it's just one time or a monthly donation, you can be part of the team that makes the show possible. Thank you for your continued loyalty and support.